Okay, so today we're going to talk about cervical spines. I love spine. As much as I hate body CT, I love spine neuro stuff, okay? I like all the spine, but my favorite is the cervical spine. And somebody may ask me, why do you like spine so much? Well, it probably has to do for the fact that when I was a little girl, I was diagnosed with scoliosis. And I have pretty severe scoliosis, in case anybody wonders why I'm always wanting to sit in the throne chair in there, because I have a 45-degree thoracic curve. So it helps when I sit somewhere that's not torture device. Anyway, but so from the time I was about 11 years old, I learned what spines were and learned to appreciate them, needless to say. So we see a lot of cervical spine in the ER, and most of the cervical spine that we see is in the form of CT. And it seems like everybody now, when they come in, they get a CT of the cervical spine. And we're pretty much right. I mean, they do. But I sat down a few days ago, because it really wasn't too crazy busy on Monday, and I thought, well, you know what? I haven't updated this lecture in a long time. This is one of my standard canned lectures that I have. And, you know, let's just make it about CT, because that's pretty much all we read. And I started thinking, it's like, no, because you need to learn how to read the plain film. Okay? At some point in time, our resources that are overutilized, somebody's going to go, no, you cannot CT every C-spine that comes in. So you need some basic skills as to how to read plain film. And as we go through the films, I'll point out the things that are corollary on CT. And obviously CT is easier to read. But you need some basic skills with reading some plain film, and that's where we're going to start with today. And this is the Radiology of the Cervical Spine 101. Now, if you would ask a surgeon, or if you would ask emergency metaphysician, how can I clear a C-spine with plain film? Okay, they'd probably look at you like you're from another planet to start with. But if that was all the resources that we had, then how would you do that? Can we do that? The answer is pretty good in all things. It's a skill, though, and it's something that you need to learn. But what constitutes evaluating a cervical spine? What do we need? What views do we need? Because you know, as radiologists, we're going to always need an extra view. Well, a lot of people think that you can clear C-spine with 3 views. Okay? And what are those 3 views? It's a lateral, an AP, and an odontoid. And I hope I can convince you today that that isn't adequate, that we can clear a cervical spine with plain film, but that we need an adequate study in order to do it, which can be obtained. And that's kind of what we're going to talk about today. What constitutes an adequate plain film study for a C-spine, and how do we evaluate it? What do we look for? So it's pretty simple, and it's pretty straightforward, and then we're going to end with some fun cases. Okay? So let's talk a little bit about spinal cord injury, a little bit of demographics about this. I apologize, I'm having some runs of PVC, so like my dry, haggy cough is kind of acting up today. Spinal cord injury is the annual incidence of approximately 40 in a population of 1 million. And most of this is caused by blunt trauma. You know, falls, MVCs, motorcycle accidents. And your standard imaging technique is a plain film. Now, let me say this. When I was a resident and when I was a fellow, one of the things that we would get, and I may have spoken to you guys about this before, when a trauma patient comes into the trauma base, what we call a trauma series. And this is in years past, and that consisted of a lateral view of the C-spine, a chest, and a pelvis. Because anything that's going to initially affect the patient radiographically that's life-threatening, you're going to see on those. Displaced C-spine fracture, pelvic fracture that the patient's hemodynamically unstable for, chest X-ray, pneumothorax, tension hemopneumothorax. And over time that has evolved. And they don't get a lateral C anymore. And you can imagine how crazy that makes me. Because not only do they not get a lateral C-spine now, they also pull the patient off the hard spine boards and put them on flexi boards in order to transfer them easier and prevent the risk of skin breakdown from pressure ulcers that can occur pretty quick, all things considered. But that's what we deal with now, you know, and Suffice it to say, it always makes me a little nervous when I see them pulling them off of those spine boards into a flexi board with no lateral film. Management of acute C-spine injury begins with a correct radiographic diagnosis, and that depends on appropriate radiographic projections obtained in a sequence that is commensurate with the severity of the injury and the clinical condition of the patient. Obviously, you've got somebody that's intubated, that can't stand up, has severe traumatic brain injury, is not going to be able to stand up and give you a lovely lateral view of the cervical spine. You need a knowledge of the radiographic anatomy of the spine, particularly its posterior elements. You need an understanding of the physiology of normal movements of the spine, an awareness of the mechanism of injury of the various types of traumatic lesions that may involve the cervical region. So those of you that have rotated through the ER before, what's one of the first things I ask you when you tell me there's a trauma staff that's in? What's the mechanism of injury? Because that makes a huge difference. And it's going to make a huge difference to you when you're on call and you're here by yourself and you're trying to figure out if something's real or not. Because if you know what that mechanism of injury is, that thing that you're not sure if it's real or not, if it fits into the pattern of injury that goes with that mechanism, then it's probably real. Now, let's talk a little bit about anatomy, to review anatomy. Now here, you can substitute in your brain, if you want to, an axial CT image of the C-spine. Same structures. Okay? So on this, just some basic anatomy, vertebral body of a cervical spine. This is the actual vertebral body itself. This is the transverse process, the foramen transversarium. This is the pedicle. This is the lamina. This is the spinous process, and this is facet. And each level in the cervical spine looks just a tiny bit different, but they all have the same basic parts. And these are parts that you need to know. And they look exactly on this, sample here as they do on a C-spine. This is with it slightly at an angle. And you can see the same spots here, the body, pedicle, lamina, spinous process. The facet, the actual part here is the facet joint, but this whole thing is called the lateral mass. And then you get these little ridgy things at the top of the vertebral body. These are called the uncinate processes, and this is kind of forms a joint space between vertebral body levels. Now, what constitutes a cervical spine series? Well, I think we would all agree a lateral, a swimmer's view, and a Den's view. But you need a good AP view, and you need some oblique views. And I want to show you why this makes or breaks the entire study as far as being able to diagnose many types of injury. So let's go through each one. If anybody's read Claude Helm's book, this probably should look very familiar with you, the initial book. This is one of the first things we all learn as first-year radiologists or senior med students or interns debating what you're going to do the rest of your life. There are I've got listed here 4 lines, but actually 5 lines that we look at in a lateral view of the cervical spine. And these films are the same whether it's a lateral plane film or if it's a sagittal reconstruction. Okay? The first line is the prevertebral soft tissue line. The second line is the anterior longitudinal line, which follows the path of the anterior longitudinal ligament. Posterior longitudinal line, which follows the posterior longitudinal ligament. The spinolamellar line, which actually isn't a line, is a confluence of shadows that you see where the lamina from both sides kind of come together before it forms the spinous process. And then the fifth line, which is the spinous process line. Okay, prevertebral soft tissue line. Let's look at a film with it here. One of the things that we tell you, these are some measurements that you need to kind of keep in the back of your head. The predental space, which is the space anterior to the dens, should be around 3 millimeters. I have it 2.5 here, but 3 would be fine. In a kid, that can be up to 5. I'm not getting the right space here. Predental space here should be it can be up to 5. The problem is that the films are very seldom true laterals. So one of the things that I do to counteract that is if I'm actually measuring this predental distance is it's a V-shaped structure, so I try to measure it in the middle, and I think that's a good average. But say 3 millimeters in an adult patient and about 5 millimeters, and 5 millimeters in a child patient. And there's several other things we want to look at on a lateral film. We want to look at the basion-dens interval, which is from the superior part of the dens to the basion, which is the anterior margin of the foramen magnum. That should be less than 13 millimeters. If it's greater than 13 millimeters, you have to worry about this dreaded thing called an atlanto-occipital dissociation. Okay, and we'll talk about that a little bit more. And then you want to look at the disc spaces. So I sit down at my workstation, and this film comes across, and what's the first thing that I do? I start looking at my lines. This is my prevertebral soft tissues, anterior longitudinal line, posterior longitudinal line, spinal lamellar line. See this little line here, spinal lamellar line? And then the spinous process is here. Okay? I want to make sure that all those are nice and flowing and smooth and form a nice little arc. My prevertebral soft tissues, depending on where I measure that, can be different widths. Anterior to C2, it should be approximately 2 millimeters. Down here, about C6, C7, you don't want it more than about a vertebral body width. Now, that being said, that's in a patient that is standing up, that is not morbidly obese, and is not intubated. How many of the patients we get in the ER are standing up, not morbidly obese, and not intubated? Not a vast majority. So just keep in mind that those are numbers in an ideal situation. And quite frequently, we can't put a lot of faith in that because of the condition that our patients are in. But it's certainly a place that you want to look. One of the things that you want to do on a lateral film too, because remember we are radiologists, so we read the corners of the films as well. Look at the mandible, look at the skull base, look at the upper chest. This helps you know how rotated the patient is. See how nice and beautifully aligned this film is? And that mandibular angles overlap each other? That means that this patient's standing straight, not rotated. Because that's going to affect how things look if the patient's rotated. And we have some examples of that coming up in a minute. So if you assess how overlapping those mandibles are, that will kind of help you put in perspective the rest of the things that you look at when you're evaluating your study. And then, of course, every once in a while, you can pick up a skull fracture on these. So don't forget to look at the corners of your films. Here's kind of a close-up. Here's some lines that we're going to look up. Here's the basion-dens interval. Here's the predental space I was talking about. Okay, this is the space again, right here. It's V-shaped. I usually measure in the middle, 3 millimeters and 5 millimeters, adults and children. The basion-dens interval, anterior rim of the foramen magnum to the tip of the dens. If you have a patient that comes in and they have a GCS at 3 and they're intubated and you CT their head and they have some DAI, one of the things that you need to consider in these patients is an AOD, atlanto-occipital dissociation. And essentially what that is a closed decapitation, okay? Because all the ligaments between the skull base and the superior aspect of the cervical spine are disrupted, okay? This is pretty much a lethal injury, and we don't see it often because quite frequently these patients don't make it to the ER. They're usually dead at the scene or die en route. I have seen several that have lived, and I remember one distinctly when I was an intern that survived. And granted, he was a vent-dependent quad, but he did survive and go to long-term care. So it's something to be aware of. It's a devastating injury, obviously. Anybody know what kind of film this is? Tom? Big Tom? It's tomogram. This is a relic. It's from a museum. Okay, not really, but this is one of the ways that we used to evaluate before we had multiplanar imaging. And that's from a tomogram. And I thought this was a cute, cool image, just something that y'all never see, just to leave in here so that you can say that you've seen it. And this is a tomogram of the skull base. And it is showing us the basion, which is the anterior rim of the foramen magnum, the tip of the den, the interval that we're measuring. And you can find the basion by finding the clivus and following it till its inferior margin. Okay. All right, and again, it doesn't matter if this is plain film or CT. The structures are the same, the measurements are the same, the alignment should be the same. Now, the cervical spine is normally lordotic, but it can be, when you look at these films, and again, whether this is plain film or CT, reversed. And that can be due to several things. It can be due to muscle spasm, it can be due to injury, it can be due to a C collar that is too big, and in up to 17% of patients, it is a normal variant. Now, remember when I told you to look on that lateral film to see if the mandibular angles are overlapped or not? Well, this is why, because if they're not, that patient's rotated. And there's two ways you can rotate. You can rotate with your whole body, or you can rotate just your head. And that's going to make this film look a little different depending on which one it is. And this one, the patient's head's rotated, not the body. And what happens with that is that you see the little facets do not overlap. They widen as you go up because the patient's head's rotated. This one, the patient's straight, but his whole body's rotated. And then in this case, the offset of the little facets are the same throughout. Does that make sense? Okay. Now, swimmer's view. The purpose of the swimmer's view is to see the lower cervical spine and the cervicothoracic junction. The problem with that is you usually only see the anterior aspects of the vertebral bodies. Okay? So that lets us know, is it aligned? Do we have like a compression fracture of one of those vertebral bodies? But the problem with this is going to be that you're not going to see the posterior elements. And why? Because the humeral head is going to be in the way. See this? So I can see the vertebral bodies nicely, anteriorly, but when we get into this area here, it's kind of hard to evaluate it. And would you really want to say that there is no non-displaced pedicolamina fracture on this patient? Okay. So I'm not a huge fan of swimmer's views. We get them because when we do a complete C-spine study, but I just, read them with a lot of trepidation because one of the areas where we see cervical spine fractures is at C5-6, and we see it posteriorly. We see pedicolaminar fractures at C5-6 all the time. These are unstable fractures. If they are not diagnosed, the patient could, end up partially paralyzed. So that's something that, we really want to evaluate and look for. Now the AP view. On the AP view, there are several things that we look for. We look at the uncinate processes, which are the upper lateral margins of the superior end plates of one vertebral body to the vertebral body above it. And where the uncinate processes of one connect to the inferior body of the next, that's called the joint of Luschko. We look at the spinous processes, and there's a lot of normal variability in that, as well as the lateral columns, which is actually the lateral cortexes of the superimposed articular masses. Okay, and this is some of the structures that we're going to look for. So here's your little uncinate processes that form the joint to Luschko, spinous processes, and the lateral columns. Now, some of the books that you might read are going to talk about the spinous processes, and they're going to say if the patient's head is in a normal lordotic type pattern, that those spinous processes in the center should be closer together, which is kind of intuitive. Okay? Unfortunately, a lot of these patients don't have a nice normal lordotic curvature of their cervical spine for numerous reasons that we mentioned earlier. So I don't put a lot of weight in that. I don't spend a lot of time measuring distances between spinous processes on an AP view. Okay? The lateral masses, though, are key. This is key. This is key. Because they should look like undulating waves. Okay? The key with that is it has to be symmetric. Dr. Hellman used to always say, God loves symmetry. And the spine is one of the primary places to look for that. So when you're looking at the lateral masses and the lateral columns, they have got to be symmetric. And I have some cases that we're going to see here in a minute. Okay? So nice and flowing and symmetric. Odontoid views. Odontoid views are hard for the technologists to get. And one of the things that you see, that you tilt the patient's head back, well, you obviously can't tilt the patient's, trauma patient's head back, right? You can't clear the spine. So they usually get these by positioning the tube submental vertex. So these are how these are obtained. And several areas you want to look for. You want to look at the lateral masses. You want to look at the base of the dens. You want to look at the dens tip. Here's a good picture of a dens here. See it? Nice. Type 1 dens fractures are at the top. Those are avulsion fractures of an alar ligament, apical ligament actually, from the tip. Those are stable injuries. Those are fairly easy to diagnose, especially on your CT, on your reconstructions. The quandary comes in skeletally immature patients where that is os-odontoideum is not fused. And those patients usually have to go to MRI to look for ligament syndrome. Fractures to the dens of the base or type 2 dens fractures, those are unstable fractures. Those are scary fractures. Those patients can pit themselves. And the reason why is you can look on this here. If there's a fracture through this line, through the base here of the dens, and the patient's head moves, then that can move as well. So 1s are stable, 2s are not stable, 3s are stable depending on how complicated they are. And type 3 dens fractures can go into the body, or they do go into the body of C2. So this is what you want to look for. You want to look at the lateral mass of C1. You want to look at the lateral mass of C2. You want to make sure that the distance between the C2 process, the dens process, and lateral masses of C1 are symmetric and that they're aligned here, 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 and that this space is normal. Okay, because if it's not, what are you worried about? Upper level? How about put you all to sleep? Are you on board? We're looking for fractures of the ring of C1. Jefferson's fractures, burst fractures of C1. Okay. This is where we find them. We're looking for fractures of C1 and fractures of C2. Okay, so C1 sits squarely on C2. The lateral atlantoaxial joint spaces are open and their continuous lateral masses are parallel. Okay, here's another view. Several things to look for in here. How rotated is the head? One of the things that I look for is I look for the space if they have, I'm not trying to be ugly, if they have front teeth, the space between their front teeth should be right in the middle of the dens. That'll help you to figure out how rotated they are still. Lateral mass, lateral mass, lateral mass, and unfortunately and quite frequently we have what's called a mock line, which is a hard palate, skull base that projects through. Okay, that's why we get the different views of the cervical spine that you saw earlier. Okay. There's your mock line. Now, what happens with rotation? And this is a mess. And unfortunately, when these patients come in, quite frequently, this is what they look like. They don't look like the nice normal view we have. They look like this. So what happens when the patient's head is rotated? The side that is rotating, the ipsilateral side of that, okay, this particular side of C1 is going to become rectangular, longer. It's coming forward towards the film. The space between the dens and that is going to get smaller. And the contralateral side is going to get more truncated. This is going to be a normal width. Okay, so that's what happens if the patient's head is rotated. Now, if the patient's head is tilted, this is a joint space. So there's some natural movement in it. And the lateral mass of C1, the lateral mass of C1 can slide on C2 by a couple of millimeters. The key is it going the same direction? Is both sides going the same direction? That's the key. Because if they're not, then you got a Jefferson's fracture. If they're going out against each other, then there's something wrong. But if they're going the same way and it's only a couple of millimeters, that patient's head was probably tilted a little bit. These are my favorite. I love oblique views. I'll wear y'all out on oblique views. If you're going to get a plain film study of a C-spine, for God's sake, get the oblique views with it. Otherwise, it's totally worthless. These are obtained at 45 degrees of obliquity. And the purpose is to evaluate the intervertebral foramen, the pedicles, and the relationship of the articular masses and/or the lamina. Now, remember when we were talking about earlier, and I said on the swimmer's view, you can't see the posterior elements of the lower vertebral bodies because the humeral head's in the way? Or guess where you're going to see them? You're going to see them on these guys. Oh. Okay? So look, we've got vertebral bodies. We've got our pedicles. Okay? This is the opposite pedicle. This is the pedicle that's facing the screen. And look at our neural foramina. And look, down here in the lower vertebral bodies that are on our swimmer's view were obscured by a humeral head, we can now see them. Okay, so LAO view, RAO view. Here's some anatomy review for your obliques. The facets, they're like little shingles on a roof. Okay. The neural foramina, articular mass, the spinous process is off to the side. And again, the pedicle, this is the opposite pedicle, this is the pedicle on the side that you're looking at. And then again, little facets are going to be like shingles on a roof. And there's a reason why. And we'll see that in a little bit. Everybody ready for test? Just in cases? Okay. Everybody get up at once. Here's real life. This is what it looks like. This is not the pretty stuff that we had before. Okay. You want to take them? Jared, you're a spine guy.
All right.
You can have the easy one. We'll save the hard ones for I know Coulter won't. So what's the first thing you want to do? Okay, so I know that we don't see these anymore. That's why we're doing this lecture today. You're like, oh my God, I don't look at this. We look at the CT. No, this is why we're doing this today. So what's the first thing you want to do?
Look at your lines.
Look at your lines. Okay, lines off.
It looks okay.
Yeah, they do. They look pretty good, don't they? Actually, the first thing you need to do is count how many vertebral bodies you got. 2, 3, 4, 5, 6, 7. All right. That's pretty decent for a trauma patient, huh? Okay, so the first thing we want to look at is our prevertebral soft tissues. Well, guess what? He's intubated, so that's all bets are off, so we're just going to ignore that. Okay? So anterior longitudinal line looks good. Posterior longitudinal line looks good. So the lines there are good. What about our spinal lamellar lines, this little guy right here? Looks pretty good, doesn't it? What about our spinous processes? They look pretty good, huh? Okay. What if I tell you his GCS is 3?
I would look at the line from the ends to the base arm.
Cool.
Start doing your measurements there.
Okay.
Good.
And I know you can't measure it sitting there, but
You can tell it's wide.
yeah, look at that. Well, I think this was probably about 18 millimeters in this patient. So this was an AOD. This is an AOD. Here's his basion. It's kind of hard to see here. There's the tip of the dent. You can actually see pretty good. This distance is grossly abnormal. Predental space looks good. Looks good here. But the basion dens interval is off. Okay, so it's an AOD. And these things, and this is weird. Where's Dr. Hardest not here today? I will go for years and not see one. And there was one year, several years back, we had 3 in a week. I don't know what happened. Anyway, okay, who wants the next case? Coulter, you want to take this one?
Sure. Let's see.
Okay. Like everything else, you gotta have a pattern.
Fine. Of course, the cervical thoracic junction is not well seen on this, but so I can't evaluate that.
Yeah.
So there's a little bit of interleucistis at C4-5. And I don't know if it's shadow, but it looks like there's lucidity through the spinal process of C2, like a hangman, but I can't really. Come more medial. Yeah, right down there.
Keep looking.
Okay.
Just remember what bone, what do we do with bone? How do we evaluate bone? We follow it with our eye or our finger, looking for rough edge, right? Tom, aren't you the one that's like, look for splinter? Look for splinters.
Deltoid fracture?
You're getting warm.
Yeah,
It's not odontoid, but you're getting warm.
Some of that.
I know, I'm weird. I like this stuff.
From.
Yeah, something in that general. Right? Okay. Okay. Does anybody see anything that looks funny? There you go. Oh, what is that? Oh. Dr. Wilson. Can you move something about? Yeah. Okay. Have I thoroughly scared y'all yet? Oh. This is a Jefferson's fracture. What's a Jefferson's fracture? Axial load injury of C1. Get a burst fracture, ring of C1. Usually, but not always. Bilateral anterior and posterior. Anterior, posterior, usually bilateral. Okay, lots of variance. Mechanism's basically the same. Okay, so this is a Jefferson's fracture. And yes, a million years ago, when I walked to school walked to work both ways, uphill to get to here, this is how we had to diagnose them. Until they could get to CT, it was pretty scary. But that's what a Jefferson's fracture looks like on one. Okay. Next, I won't pick on Carson or Daniel yet, unless they want to be picked on. You want to be picked on? Sana, you're hiding in the back. You take this one. So what's the first thing you want to do when you see this guy?
How many vertebral bodies?
Not bad.
Look at the lines.
Okay. And how do they look to you? How do they look for you?
They look fine.
Prevertebral. He's not intubated, and that looks pretty good for one of our trauma patients, doesn't it? Make me happy. ALL's okay. PLL's okay. Spinal lamellar's okay. Spinous process is okay. Okay. Pretty rotated. Look how far back his mandible is. All right. Well, vertebral bodies are nice and square. Disc spaces look like they're maintained. Okay. The sets are aligned. Let's look at that one.
At least you didn't fracture his good tooth.
His tooth? He didn't fracture his tooth.
You got a good tooth.
He has a good tooth. Okay. What about this one? Something standing out?
It's a mass effect.
Granted, he's kind of crooked, but it's okay.
Is it between 3 and 4?
Let's see.
The set?
There's probably 2 up here. I think that's the dens there. 3, 4. So what did I tell y'all about lateral masses? Oh, it's like I dream of Jeannie. Okay. All right. Do you see anything there?
On the left side.
Yes, on the left side. It's drink is junk, but I'm just going, hey, look at me. Okay. right here. All right. So let's see what that is. So what type of fracture is that?
Is that for a particular process?
What's it involving? Pedicle, lamina, pedicle lamina fracture? Okay. So it's a pedicle laminar fracture. It's an unstable injury.
It's a what fracture?
Pedicolaminar.
Pedicle.
Yeah, pedicolaminar fracture. And this is an unstable injury. And we see these all the time. All right. Oh. I actually published this case in AJR in the last century. It's a pretty old case. This is a great case. You want the history? History, 4th of July. Little girl sitting on her father's shoulders at the fireworks in Gasworks Park in Seattle. Fell off her father's shoulder onto her head. Comes in the ER. She's evaluated. And if it makes you feel better, makes everybody feel better, she was sent home with no injury. UW's a top 10 program, so make everybody feel better. They miss this. Okay? What about this one? And you can ignore the publication arrow back in the days where you actually had to put rub-on arrows and stuff.
This is the same case?
Same case. She comes back. This is like 2 days later.
Oh, this is the back, coming back one?
She comes back 2 days later. Let's see what it looks like. Oh, that's not good. Okay, so pedicle laminar fracture. So 2 cases of pedicle laminar fracture. The best way to find them is the flowing lateral masses. Okay, it's supposed to be the same on both sides. All right.
When they do the oblique views, like the, what is it, RAO or RPO, which one do they do? The obliques?
It's A, RAs, and
And is the right, and the
yes,
left
it's the left.
What about lumbar spine? Same?
It's the same, I think.
Opposite?
Yeah, I think it's the same. I'm pretty sure it's the same.
Dr. Martin, can you go back to that initial film of that case, the lateral view? Yeah.
That one?
Yeah, just kind of weird, the lateral view, it's just positioning or something on the lateral view, on the left side. Yeah.
This one?
Yeah, kind of.
Yeah, she's like lost her cervical lordosis. The thing with pedicle laminar fractures, you're not going to see them on the lateral. You're not. You're going to, that's why I keep pounding in oblique views. You're only going to see them on those. Or the AP. You can at AP too, but you cannot. As bad as that fracture is, you don't see it on this one. It's right here though. See how that's off? See how this flowing. That one's off a little bit. This is a little kid, so she shouldn't have any abnormality like that. You know, she's my age up here like this, and you saw kind of an, articular mass like that that's off a little bit, then you probably think, oh, well, there's probably some degenerative change there. But this is a child, so she shouldn't have anything like that at all. So this was what was missed. And when it comes back, it looks like this. So it's moved. And then this was her AP on that one. Yeah, absolutely.
So, Dr. Martin,
Yes, ma'am.
the fact that the anterior spinal line and the posterior spinal line on the lateral view are like wavy shouldn't have alerted anything?
Oh, her? She had some reversal of her lordosis because she's in pain. Okay, so that's another signal too on that one. Okay, on that lateral film, this is a kid. And she's like this in getting her film done. She is actually in pain. A little kid's not going to probably know enough to, do something like that. She's really hurting.
Little kids, when they have their necks flexed, you can get pseudo-subluxations on that little posterior and anterior line, but the spinal laminar line should be perfect.
And honestly, you know something that you brought that up, let me make this point too, because I'm not really sure at what other time I would make this point, and it's something that's anecdotal for me over the years. You know, I've seen that up into 18 to 21-year-olds. You know, and you're going to hear, you're going to see that on call. Everybody's getting ready for call. You're going to see some pseudosubluxation. It's just a given. It's just when you're going to see it. And you're going to say, hey, I think this is just some pseudosubluxation. And they're going to go, oh, well, but they're, 18 years old. It's okay. It will happen.
It's a variant,
It's another pedicle lamina. Okay, is this where we were? Okay, who wants this one? Where were you? Let's see. Tom, you're back there in the very back. Normal. CT it. Which is probably what happened. But what if you're like me laying somewhere and they don't have a CT scanner? Techs, they only have tech till 5 o'clock. So.
It's like there's increased distance between the spinal process C1 and C2.
There. This place there? Yeah. That's part of the complex that's going on with this. So we 2, 3, 4, 5. Well, we don't see everything here, do we? Can't really evaluate prevertebral soft tissues. They've got tubes in AL, PL, spinal lamellar, spinous process. Those all look pretty good. So now we got to go to our next set of evaluating. And y'all know I hate numbers, but you still got to look at it, okay? So predental space, there's the dens, predental space, there's probably about 2 millimeters. Looks up to me. That's wide. So where do I want to walk? I'm going to tell you again, because you would know this. This patient's GCS is 4. You want to guess how much that was?
17.
Now, first year's listening to me. What do y'all think this is? I gave it away.
What did she call it? You said 13, but what's it give us more than 13? What do you call it? AOD?
Yay, yay. Yes, this is another one.
AOD.
I told you, you won't see one forever, and then you'll get like bam, 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 3 in a row. All right, it's another one. Okie dokie. What about this one? Who wants this one? Who are we up to? Luis, we're up to you.
Frontal lateral views of the cervical spine. We can see 1, 2, 3, 4, 5, 6, 7. We can see the cervico-thoracic junction. I'm going to say well, but the T1 I don't see it quite well. There's the lordotic curvature is preserved. The predental space is normal. My lines, the AP line is okay. PL is fine. Spinal laminar line is fine. Spinous.
And you can ignore the gnawing pain in the neck. Sorry,
At
my joke.
Front,
Yeah. Focus on this.
I haven't found anything yet. The left border looks a little bit asymmetric. Probably I'm making that up.
No, you're not. No, you're not. It's a good pickup. It is. It is. It's asymmetric. Yeah. Something's not right here. And it's okay to go, I don't really know what it is, but something just don't look right. Because they're going to go to CT anyway, right? in most scenarios, this would go to CT. The important thing here is that you realize that you see something like this, you know, oh my God, don't take them off that spine board. Don't take that C-collar off. They've got to go to CT. Okay.
If their face like
This is not normal. Okay, so I'm going to really scare you when I show you this. And pay attention. Do you see anything wrong on that lateral? No, there's nothing wrong on that lateral. Okay, this is another view. Optimized a little bit. Look at this. Look at this.
Why is the lateral mass?
It's like it's rotated. Remember that one I showed you, the little girl? Does it look like that? These look like that? They're kind of rotated out. We're going to run out of time. I want to get through the last couple of cases here. Okay, this is 2 levels of fractures. This was in C6 and C7. Yeah, look at this. This got bilateral pedicolamинars and then a pedicolaminар here on this side, unilateral.
Things feel very subtle and
It is very. It is very much so. But the key is to see, even though, I mean, I don't expect you, I don't think anybody would expect any one of us to look at it and go, oh my God, they've got bilateral C7 and left C6 spinal pedicolaminar fractures. What I want you to be able to do is look at it and go, something's not right. There's something that's not right here. We've got to see this. Okay? All right. We got 2 more cases. Who left? You missing?
Let me go to so we see 2, 3, 4, 5 on the first lateral on the pseudo view. You can see 2, 3, 4, 5, 6, 7, and C1. And there's a bony fragment. And it's also a small
This one you can diagnose. What did you tell me is going on here?
C6 is fracture. There's a fragment.
Yes.
And then it's also posteriorly sublong.
Yeah. Here you go, guys. So 2, 3, 4, 5, 6. So there's a C6 vertebral body fracture. And of course, we are going to CT it because usually nothing's going to be that simple. See a little bit better here. Okay, so it's a C6 vertebral body fracture, and there's also facet fracture on this one. Okay, one more case real quick before they run this out.
Was this a teardrop?
I don't think it was. Teardrop fractures, there's hyperflexion and hyperextension teardrop fractures. You know, hopefully one day I'll ever have time that we can do those. But hyperextension teardrop is the one that's a devastating type injury. Anyway. All right, last case real quick. Anybody want to take this one's up for grabs? Okay, so 2, 3, 4, 5, 6. We don't see the 7. 2, 3, 4, 5, 6, 7. Okay, so we look at our prevertebral soft tissues. Those look okay? Oh. What about our anterior longitudinal line? Yeah. Okay, so let's follow it down, follow it down, follow it down, follow it down. Okay, well, maybe it's just because he's got all this degenerative change. So let's look at the posterior. Uh-oh. Let's look at our facet. Roof shingle, roof shingle, roof shingle, roof. So what you want to do? You want to take this guy a collar?
Extension inflation.
Yeah, extension flexion, use that. That'll work. Oh. Anybody know what this is? Coulter, what is it, buddy?
Hamburger? Oh, sorry. Of course, it's so like cold thing.
Yeah. Just tell me what it is. You'll have to describe it. What's the diagnosis? Yeah, it's a unilateral jump facet. Okay, this is normal. Okay, I know probably Dr. GT or Dr. Hart has talked to you guys about this before. Normal facet should look like hamburger buns. You get a reverse hamburger bun sign, like you take the buns and you flop them from on top of each other, like that one over there. That's the jump facet. Facets, instead of doing this, are now like this. Okay, unilateral or bilateral. This is a unilateral.
A horrible term is locked facet, because locked facets are not locked, especially if they're bilateral.
Yeah, I know Jared's probably had to treat these before, but I remember when I was a fellow, we had to fluoro for neurosurgery while they put these in traction. Because that's the way they reduce them. They put them in traction until they pop back out.
They just hang weight on them, give them a lot of muscle relaxers.
Yeah.
For the neurosurgeons?
Yeah, it's nerve-wracking to watch it. You're just like, oh my God, they're going to rip their head off. All right, that's it.